Welcome to the HIV podcast. Each week we focus on a person, historical event or pop culture moment linked to HIV and explore the story of what actually happened. I'm Sarah.
And I'm Jess, and between us we've been working in the field of HIV for 40 years. Our aim is to get as many people as possible HIV educated.
Okay, welcome. What is it? Sorry, welcome to the
Yes.
welcome to the HIV right. Welcome to the HIV podcast.
Didn't sound too serious. Sometimes when we ask people to do it, they go super serious.
Oh, no, that's my telephone voice.
I like it. Right. Oh, this week, Jess, we have a very, very special guest. She is an HIV specialist nurse at one of our local sexual health clinics. It is the lovely Liz Tarrant.
Now, normally, Liz, we'd try to give you a round of applause, but every time we do that, I say this every single week, all of our microphones cut it out. So let's imagine the applause happening. Yay!
Hi.
How are you?
I'm good, thanks. I'm good.
Excellent.
Thanks for having me.
You might not be excited by the end of it.
Oh, well, we'll see.
We'll see how we go. So we've got lots of questions for you. And the first one that I think we'll open with is to find out a bit more about what happens when someone attends the clinic for an HIV test. So, what sort of test, how long would they wait for results? How are they contacted with results? All of those sort of questions.
Yeah. Obviously, I can only speak from our experience at Reading. Different clinics do different things. They have different tests. But generally, when someone comes into the clinic for a test, they'll have an assessment first, and it's just so that the nurse or the healthcare professional can kind of work out window periods, risk. So we try to do a blood test is the preference. We do also have the instant finger test, but we do prefer to do a blood test, and we're really working towards trying to make sure that everyone who comes to our clinic has an HIV test. We're really working towards the opt-out service instead, because at the end of the day, everyone who comes to a sexual health clinic is at risk of HIV. And I think it's really important that we're aware of that and offer those tests to people who maybe don't realise that they would have been at risk. So we go through the risks, as I say, talk about window periods, because sometimes you have to wait a certain amount of time before you have a blood test. We would still encourage you to have one when you come in, but we know that the results are accurate on a blood test after 45 days of your last potential exposure to HIV. And then the finger prick test, they vary, but can be up to 3 months from exposure for it to be an accurate test. But I know that different clinics do different tests. Yeah, so once you've had the blood test, it gets sent off to the lab, and it takes up to 2 weeks for results. Obviously, if we were alerted for a positive test from the lab, then we would not think, oh, well, we'll just wait another week before we tell that person. We would contact them straight away. It is a phone call from our health advisor team. We've got an amazing health advisor team at the Florey Clinic. We're very lucky. And we would ask them, the person, to come back to repeat tests. We don't generally go into details over the phone because it's an important test and it needs to be done in the right way. But equally, if you get a phone call from the Florey Clinic, don't automatically think that it's going to be news that you've had a positive HIV test. It might just be that a sample's been lost, or we need to confirm your date of birth or something. So don't panic if you see that we're calling you. It doesn't always mean that it's a serious conversation that we need to be having with you. Yeah, so the health advisor will always try with a phone call. If we can't get through, then we will try with a text message to say, can you please give us a call? So we will do everything that we can, and sometimes we do need to take other routes to get in contact with someone, but we will do phone call, text, asking you to call us. We've got other numbers that we can use to try and contact you on. So
the important thing is then that if the clinic contact you after you've gone to have your tests done, it doesn't necessarily mean that you're HIV positive or that you've got any other positive results through, because that's what everybody jumps to that conclusion, don't they? And I'm sure then some people just go, right, well, I'm just not going to answer the phone, then it's just not happening.
Yeah. And it might honestly be something like, oh, we're so sorry, but your result it hasn't been processed, so we just need to get you to repeat it. Or it could just be something really minor, so don't hide from us. And
you will text, you will hunt.
Yeah.
No, not that you'll hunt anyone down, but you will. Yeah, you will follow up, won't you? You're not just going to be like quick phone call and that's it. No, it's
no. Yeah.
Okay. And I suppose it's important to remember the volume of tests that you do and that the lab do, because they're not just processing samples from the sexual health clinic, they're processing samples from the whole hospital.
Yes. Yeah. And they go off, some go off site as well. So it's, generally it's fine, absolutely fine. But things do happen. So sometimes not often, but we might need you to come back in and repeat a test or something, or you might have something called an equivocal result. So they can't say it's positive, but they also can't say it's negative. So sometimes we just need to have a conversation with you. So like you say, Sarah, please don't panic, but also please don't go into hiding if we do contact you.
Yeah, that's fair enough.
Yeah.
Okay, so if you do follow-up tests and you're absolutely certain that they're HIV positive, you invite them back in to the clinic.
Just to go back a little bit there. So once someone's had that first HIV test, they come in for a confirmatory.
Right.
So we don't confirm anything on after that first. So if someone's come in for a general test, that is not confirmed until they've come back and they've spoken to the health advisor and they've had a confirmatory done. 9 times out of 10, that first test is correct. But as I said before, it's an important test. So we need to really double check that. So we always do a confirmatory. So that's on the second visit.
And so is part of the sort of rationale behind that to obviously to make 100% sure, but because the chance of getting a false positive twice is almost impossible. Is that to do with it?
Yeah. So we always do that confirmatory. So when someone comes back into the clinic after they've been contacted by the health advisor, they meet with our health advisor. And the conversation that they have is that your test has come back and it's shown that it's positive, but we do need to do a confirmatory to confirm that is the case. And the health advisor, if it's appropriate, they really judge the situation, because some people want to have loads of information. Some people just say, just do the blood test and send me home, please. I don't want to talk anymore. But the health advisor does try and have a chat around what HIV is and the tests that we'll be doing today and what that might look like for that person, that if that second one definitely comes back as positive, because chances are that second one does come back as positive. So a lot of the conversation that we have is preparing them for that eventuality, because also it's not fair and it's not right for us to give people false hope. You're not being a responsible healthcare professional if you say, oh, actually it'll probably be okay, when actually you know that chances are this test is going to come back positive again. So the health advisor, if they feel it's appropriate, they do talk about HIV, a viral load, a CD4 count, because we do a big set of bloods when someone actually comes in for their confirmatory test. And that's so that we're one step ahead, so that when that second test probably will come back as positive, so that we're prepared. We've got a really clear picture of what's going on with that person's health. We can intercept earlier. Say if their CD4 count is already showing to be very low, then we can start them on the necessary protective medication. And it just means that we've got the ball rolling so that they can see a doctor as soon as possible with that set of results, because the results can take for the more in-depth tests like your viral load, your CD4, can take up to 2 weeks. So it means that we're set up and we're good to go for once that diagnosis has definitely been confirmed.
I had no idea that actually that confirmatory test, you also took all of that information so that you were armed and ready with CD4, viral load, everything. That is so sensible.
Yeah. Well, I think because the results take 2 weeks. So when you see someone and you do all of their bloods, their viral load, you do a resistance, you do TB testing, you do a whole load, that can take up to 2 weeks. So then you really want them to see a doctor 2 weeks after that first diagnosis. So you're prepared. I think we used to do, I think, a CD4 viral load, but actually it's so much more use now to have everything, because we start people on treatment so much sooner now as well. You really need to get them started as soon as possible if it's appropriate. Obviously it's not appropriate for everyone. Not everyone is in the right place to start, and that you must never rush or pressurize someone into starting antiretroviral therapy because it's lifelong, but also if you can get them started as soon as possible, it's much better for their long-term health outcomes, and research has shown that. So yeah, so they have lots of bloods done. I always say to people on that first visit, I know it's really scary, but I can promise you that you will not have this many bloods done again. So because it's quite daunting, but it really is just so we can get a clear picture of what's going on.
Okay.
So in that visit, I try and pop my head in as well. Usually I'm the one doing the bloods. If I'm around, I have booked appointments for other patients sometimes, but if I am around, then I will try to be. And also it's an opportunity for me to meet someone who I'll probably be providing long-term care to.
Yeah, so that it makes sense, doesn't it? So once they've had the diagnosis, they meet with their consultant, and then they are under your care. Well, it's kind of joint, isn't it? Yours and the consultant.
Yeah, and the health advisor, depending on what's going on in that person's life at the time. If they need a bit of extra support, they might meet the consultant earlier on. They might meet the consultant on the day that actually they come back and have all of those blood tests, because they're already showing symptoms. Perhaps they're already poorly. Perhaps that's why they've tested. And they might have some other symptoms that we think could be related to HIV that need managing and need treating. So it really varies for all patients, really. But the main thing is that on that first visit, the health advisor. So I guess the health advisor really deals with those initial first positive results or reactive results, and then I come in, do my bloods and do my hello and additional support as well, and then the consultant comes in probably about 2 weeks later at that first consultant appointment.
And do people see the health advisors much after that point, sort of throughout their care, or are they more like that first frontline sort of contact point?
For some people living with HIV, life can be very complicated and they've got lots of other things going on. The health advisor will help with things, for example, partner notification. Well, actually, for lots of people, perhaps they just don't want to talk about partner notification at that first visit, and that's fine. And we're not going to force anyone into doing anything that they're not comfortable doing. And we always want to be supportive. So perhaps the health advisor might just dip into care again, a month down the line to help. But actually, for one person, they might be able to say, well, actually, I've already told my partner that I've tested positive and we're fine. He's come in, he's tested, and that kind of ties it all up. And then the health advisor will, I suppose, discharge them. But we're so lucky that we've got health advisors in the clinic. So if there are even issues down the line, our health advisor helps with chems use, all sorts of things, referrals for social prescribing. If someone's been sexually assaulted, they're a really, really skilled team. So sometimes I unfortunately don't have time in clinic, and I'm not necessarily skilled to do so either, to talk about if someone's been sexually assaulted or something. So then that's a real seamless process. Then I can say, I can't talk to you about, maybe I'm not equipped to talk to you about this, but I'd really like you to see our health advisor team. So we're really lucky that we can dip in and dip out as necessary. And they come to our meetings. I'm often just popping my head into the office saying, oh, can I talk to you about this patient? So we're really, really lucky to be able to lean on them. So
well, it's very patient-led. I think sometimes people's perceptions are, once you're diagnosed with HIV, that's it. It's all out of your control, forced onto medication. And I absolutely understand what you're saying, that medication, you should take it straight away. But I think, some people need a little bit of time just to process what's going on. So that's really reassuring. Yeah. And then the other thing is that it's quite tailored, isn't it, to individual needs. It's not a production line. No.
Do you mean medication, or do you mean the whole process?
I think the whole process. I think this is a public perception. Actually, I think it's a perception of NHS, not just sexual health clinics, that they are overwhelmed with the volume of people. True. Underfunded. True. But because of that, you're in a production line and you're just going through the motions to get the treatment that you need.
Yeah.
And that is most definitely not the case.
No, it's definitely not my experience at all. And that's from, as I said, starting someone on treatment. We know that if someone is not ready to go on HIV treatment, the worst thing you can possibly do is force them to do it, because they will disengage. You'll never see them again. Or if you do see them again, they've developed resistance because they've not actually been taking their medication properly, and they've lost trust in you as a clinician. They think, well, they're not going to listen. So we really try so hard to keep that the communication open all the time. And I often say to people, just talk to me. I can't do much if you don't talk to me, if I don't know what's going on. But we know that people who take their antiretrovirals, and if they feel supported, so with peer support from you guys, but also being listened to and patient-centered care, they do so much better. And we have our weekly multidisciplinary team meeting, which involves the consultants. We've got a dietitian, we've got the health advisor, we've got the admin, we've got 2 amazing HIV administrators, the specialist nurses. So we have those meetings every week, and some of those meetings, they are really medical heavy, and I think, oh gosh, I don't understand, some of this is really, really complicated, about really complex resistance. But then actually some weeks it will be, I'm really concerned about this patient. This is why I've brought them to the meeting. They've got this going on. They've got this going on. How can we help them? So it's, and even when we're planning someone's antiretroviral treatment, we ask things like, are you on contraception? Do you think you might would you like to have a baby in the future? Do you do shift work? How do you find taking regular meals? So we take all of that into consideration so that people can maximise their success, really.
Yeah, you're
awesome.
Not setting them up to fail, are you? Not at all.
No, exactly, yeah. And it's, again, taking it back to being patient-centred. So I hope that the patients who certainly come to the Florey feel like they are supported. But I think that HIV medicine, generally, I think it's, and sexual health, from what I've experienced, I think that generally it's certainly an area of healthcare that is patient-centred. But I do think generally, as you say, Sarah, the NHS on the whole, they try and be as patient-centred and patient-led as possible, because I think we're just starting to realise that people don't necessarily respond to us telling them what to do. So
I think that's it's so true. And I think getting the public to understand that message, especially if you're not going through any sort of treatment, I think you can very much believe that, it's not like that. One of the things we wanted to check with you, we get this from some of our service users, is they'll miss an appointment or several appointments.
Yeah.
And then they'll say to us, well, we can't go to the clinic because they'll be really, really cross with us.
Okay.
Because, part of our job, so sometimes they'll engage with us, but they won't engage with you.
Yeah.
And we always check if people are regularly engaging with the clinic. And if they don't, what's the challenge? Could we come with them, kind of overcome that barrier? But yeah, it's always blamed on the Florey units. And no, they'll be so cross, I better not go. That's not true, is it?
No, not at all. No, I've got a whole pathway written to try and re-engage people. We have got a flow chart that so we try different things. So it starts with a text, and if you don't get a reply after a text, I'll try another text, and then it's maybe a phone call. No one will ever be angry or judge. I think all healthcare needs to be non-judgmental. It's in all of our code of conduct. It's certainly in my NMC code of conduct to provide non-judgmental care. As a side, no, not at all. We understand that people living with HIV are human, and they are living the lives that we've wanted for years for people with HIV to live. Having a job, having a relationship, having children, all of the things that actually years back they wouldn't have had the opportunity to have. So we know that life gets busy for people. We know that actually health, when people are living with a long-term chronic condition, health is usually, unfortunately, the thing that falls to the bottom of the priority pile, because actually putting food on your children's table and paying your mortgage or your rent and getting to work and all of those things, that becomes, and trying to manage relationships and all, that's part of holistic care. It's not. I say to people, I am interested in your blood test, and I am interested if you're taking your medication and all of those things. But actually, all of that is pointless if all the other stuff in your life, if you're feeling awful because you're depressed, or if you can't make ends meet. There are so many other important things. So I would never ever judge, never be angry. I'm always happy. We are always happy when people come back into contact.
I was going to say, we've never actually had a report of the Florey ever being angry. We should just point that out, ever. It's just all in people's heads, isn't it? It's that, kind of, oh, my mum's going to be angry with me type thing, isn't it?
They don't want to let you down. It's like, you're not letting me down at all.
Like, that's right. No, it's important to say it's not just the Florey, it's all the sexual health clinics we deal with.
And that's, I get it. That's fine. No. But I think as I say, I'm always just really happy. From a selfish point of view, I think, oh, great, I can stop hounding this person now. And I don't hound. That sounds terrible. But I can, I know where they are. It's because I will keep trying. And it might be that I try initially, or we try every month for a little bit, and then it starts to peter out. And then maybe we might contact, if we've got permission to, we might contact someone's GP and just say, have you seen them? Because not to tell tales, but just please remind them that we're here for them. And that's what I generally put in the letter, that please remind them of our service and that we would really like to see them. Because also, if someone is going to a GP and they're not on treatment, then their GP should probably know that. But just to reiterate, we do not speak to GPs unless we've got clear consent from a patient. If we've got consent, then we will speak to a GP. And as I say, I'm always happy to welcome people. I'm a bit of a detective. I like to know where people go. Where have you been?
Oh, I'm a bit like that. It's the mum in me. I just want to make sure everyone's safe and well.
Yeah. And I think, that person go? Yeah. Even now, I still think, I'll just be driving along one day and think, where did they ever go? I hope they're all right. Usually, and often it is that someone's moved on, perhaps they've met someone in Scotland and they're living their best life, and I really hope that is the case, rather than people feeling scared or that we're going to be angry with them, because we're not. I would also just say that if you do feel like you're having a wobble and you don't want to come to clinic for whatever reason, just had enough, you've been doing it for years and you're just a bit sick of it, or if you're looking at your meds and thinking, I don't want to take those, or you've got to order them, or any of those things, or you've just been too busy, just speak to us early. So we will always try and be flexible to fit you in. We would rather someone miss 2 appointments rather than 10 appointments, or, and we would rather put the support in early to stop that from happening, because we refer on to you guys, we can help refer on to talking therapies, the health advisor team. If you might just need a phone call from me if you want, or Lindsay. Might not want that might be the worst thing that I could possibly offer, a phone call from me once a month just to kind of see how you're doing. There are extra things that can be put into place, again taking it back to that patient-led and patient-centered care, that some people do just need a bit of support. Some people are absolutely fine and, just do what they need to do. But other people, life is complicated for everyone.
It really is, isn't it? And especially the last few years with the cost of living crisis and everybody struggling.
And 0 hours contracts and stuff like that. I get that it's not actually easy for people to come in for their appointments. But if you speak to us, then we can work with it. Don't go off radar.
That's the key, isn't it? And that's because I think for some people, especially around having a break from their treatment, which we sometimes hear from people, and it's often a cry for help, isn't it? Life is so tough right now. Do you know what I'm going to do? I'm just going to stop taking my meds. Yeah. And I think the worst thing that we could say to that is, well, don't do that. That's a terrible decision. Instead, you kind of need to validate how they're feeling and go, actually, speak to the clinic about this, because, it's your body. Yeah, your HIV, and they're here to support you. Yeah, yeah. And for them to make sure that if that is a decision that they make, we would obviously actively discourage that.
it's making sure that people understand the data, the research, it makes sure that they understand the consequence of that. But I'd like to think that it doesn't often get to that. It really doesn't get to that case. And we're so lucky that we've got such a great support network from you guys. And as I say, our health advisor team and myself and Lindsay, the other specialist nurse. So yeah, but just speak to us.
Yes,
I
this is
can't.
what we always regard
Yeah.
as like a cop out for us. It's like, go and speak to Liz and Lindsay. Shared with the
We do the same with you guys. I'm like, oh, I don't know what to do with this patient. I don't think that I can offer anything else. Oh, TVPS. Yeah. I'm always really careful to manage expectations, though. If I'm phone housing, can't find you a house, but things like the amazing, the help that you give people to complete forms and all of that. So,
okay, so what's coming through loud and clear as you're talking is this very caring side to your clinical role. And I think we find the same here, is there can be an emotional toll in doing that. How do you kind of keep that work-life balance and not just take everything home with you?
So it's not easy. Not every day. Some days you have to really be conscious of looking after yourself and your own well-being, because you can't. What did they say? You can't fill from an empty cup, or whatever.
Yes.
Yeah. And I think that I've been doing this role for like 10 years now, actually. Which, gosh, that makes me feel old.
That gone quick. Oh my goodness.
10 years. And I think that I've learned things along the way, and there have been times when I have felt very burnt out, and I think I've had to take a step back and get a bit of support myself. And because if I'm going to promote things like therapy and talking to colleagues and looking for, and I encourage my patients to do the same. So then, sometimes I've had to take a step back and think, I need to go and speak to someone about this, because this is a lot. This is really heavy. Now, at the stage that I'm at, it's even more important that I look after myself, because I've got a young family. I think probably a few years ago, before they came along, I would put in hours and hours, and I would stay late, and I would go in super early. But then I guess I started to realise that probably wasn't the healthiest thing. I'm at the point now where my well-being comes from, I exercise a lot. I go to the gym. My husband knows I have to go to the gym 4 times a week. Otherwise, I'm quite miserable to live with. I think I've almost trained myself to try and leave things at work. And that's not to say that I don't think about people at the end of the day, because I absolutely do. I sit in my car and I'm driving home and I'm thinking, oh, that's worrying me, or I think I could have done that a bit better, or tomorrow first thing I must make sure I sort this out. But I think it's taken a few years for me to develop the ability. It's almost become a bit of a skill. When I was a newly qualified nurse, I would laugh, and I spent most of my first 6 months crying in the linen cupboard. I hated it. On the wards, I was always in there crying. And I just think it's something that comes with working in this job for a long time. You start to understand what you can change, what you can't change. You do go in, you do your very best every day, but you also need to, if you've got a family and you've got things that are going on outside of work, you need to be able to give them your all as well. So I think the thing is asking for help when you need it. We've got a really supportive, my colleague Lindsay will often just have a chat and say, oh, do you mind if I just talk to you about this? And we can just have a conversation. The MDT, so that weekly meeting that we have, can be really helpful to get other people's opinions on situations that maybe we're just a little bit not really sure what we need to do, and just to say, for someone to say, no, you did the right thing there. We've got through our work, we have occupational health, where we can access counselling and things for ourselves. So I think it's just starting to realise when you're feeling a bit frazzled and a bit burnt out. So, but for me, exercise is the gym. The gym.
What's your favourite thing to do at the gym, Liz?
Oh, weights.
Oh, nice. What do you
Yeah.
like? I like the leg press.
So I've got bad knee. So the leg, the leg press is, I do go on it. So I quite like a deadlift. I like going in the proper weights area and feeling like a big.
Yes,
Oh,
yes.
yeah.
Yeah, I love that because it's
Yeah.
quite like monopolized, isn't it, by like quite big men, and it can feel intimidating,
String
but
vest.
but it's like owning the space, isn't it? It's like, no, we all get to use this space. This isn't just for people like you're saying in tiny vests.
Yeah.
You know,
Thank goodness.
monopoly.
Yeah. Thank goodness my gym is very inclusive of all and everyone. So
Nice.
yeah, but I don't do cardio. I don't like being sweaty. Or out of breath. No, I can't do cardio. So it's like my husband says, you're built for strength, not for speed.
Oh.
And he says that there's a compliment in there somewhere. Yeah, but I don't know where I'll be without exercise, really. I only kind of found it. Well, actually, I found it because I wanted to get into a small wedding dress. And then I realised that actually that was 10 years ago. And then I realised that there's many more benefits to exercise other than weight loss. I mean, how boring is that? So
I think more so in the last 5 years, especially, we've all become much more conscious that we can't take care of others if we're not taking care of ourselves. I think that there used to be that real culture, didn't there, of, you know, working hard, and if you're in the earliest, if you're doing the most. But we can't sustain those things if we're not, you know, like you say, finding other things like exercise and saying, actually, this is my working life and then this is my family life, and there has to be a separation there. So like you're saying, you're practicing what you preach.
Yeah, exactly. It's all, I can't sit there and say to patients, have you thought about talking therapies or peer support? And then just inside thinking, I'm so burnt out and I'm exhausted, and then just not doing anything to make myself feel any better.
One topic that we should touch on, mainly because I'm writing a funding bid on it at the moment, is around older people.
Yes.
So whether that is testing for, well, let's start with older people wanting to test for HIV, because more older people are diagnosed late, we find, than any other age group, possibly because their perception of the sexual health clinic is that it's for young people.
Yeah.
Which is, it's fair enough, but I guess I'm interested in your views on, is it a very young environment, or are there all ages there?
Yeah, all ages, all backgrounds. On a day, I can walk through the waiting room. So just bear in mind that I tend to see patients after they've tested positive for HIV. So I don't do the screening anymore. That did used to be my role when I was a sexual health nurse. But we could see someone from the ages of young, sort of. We've got specialist nurses who work with our younger people, our 13-year-olds, our young teenagers, right up to 70s, 80s. Certainly on the HIV side, we've definitely got patients who are in their 80s, which is just amazing because it shows how amazing HIV medicine is, because these are not people who've been diagnosed recently. These are people who've been diagnosed a long time ago. But you could be coming into a clinic and you might be sat next to a 16-year-old, but also you might, on the other side, might be a 65-year-old, 70-year-old. So we see people from all walks of life. But there is the home testing service if you're in West Berkshire as well.
Yes, of course.
So if you're not comfortable coming into clinic, then do go to Safe Sex Berkshire. Just go to our website and you can request a testing pack if you've got a West Berkshire postcode.
And that includes an HIV test, doesn't it? Because we obviously let people know about this. So it's an STI test kit with an HIV test. And we will put, obviously I know this podcast goes out around the world, so not that helpful, you know, if you're in, I don't know, Mexico. But if you're in West Berkshire, I will put the link below. And you can order a postal STI test kit with an HIV test.
We've also, at the moment, we've got to try and test as many people as we can. We've got so my colleague said, don't call it a bus. It's not a bus, a van. She said, you're upselling it. It's a van, which we'll be doing. If you follow us on social media, the Florey Clinic on social media, we are popping up all over. over the coming weeks and months. So we're doing Newbury Pride on Saturday, I understand. We're doing, I think, the Kenyan Festival in Reading. We've got some sites in Whitley. So, yeah.
That's awesome. You've literally stolen Sarah's dreams.
Oh, my sex bus.
Oh.
Wanted to call it the Sex Express, didn't we?
Oh.
Oh, how cool. So this is like mobile testing. This is going out and into the community. I love it.
Yeah. So that's an option. But for someone who doesn't feel comfortable coming into clinic, then probably a home testing kit would be the best option. You also get the results really, really quickly within 48 hours. So if it's something that you feel particularly nervous about, if you feel like there has been an exposure that you are particularly concerned about, then actually you'll have those results in 48 hours. So whereas, you know, the clinic it is up to 2 weeks. But going back to the non-judgmental care, you know, people who work in sexual health, we've seen it all. I think healthcare generally, we've kind of seen it all. There's been nothing's going to shock us. So come in, have your test. It's the most responsible thing for your health, for other people's health. And although having an HIV test can sometimes feel like a really scary thing, just the benefits of testing, you're stopping yourself from getting poorly, you're stopping further transmission, so you're not passing it on to people. Knowing your status is always going to be much better, always, even though it's can feel like a scary thing to do. Just test. And I really hope that we get to the point where HIV testing becomes the most normal thing, from being 16, from your first sexual experience right up to being very mature with your sexual experiences. Just test. It's such a beneficial thing. And I think things like the mobile testing, the starting to test in A&E, starting to test in different areas that aren't necessarily conventionally sexual health, is going to really reach those people who wouldn't maybe think that they've been at risk or just feel too scared to test.
Oh, there's so much hard work going on at that clinic, isn't there?
Busy bees, yeah.
All these new initiatives, and I think you're right, it's making it accessible for people, it's normalising it, and that's what we need to do.
Yeah, for sure. And I think that will go so far to reducing stigma as well. You just go to the clinic, you just have a test in the same way that you have a diabetes test. But then I'm not trivialising how people feel about testing when I say that, because that's the dream, that we will get to that point. We're not there yet. And I think that when you work in an area, you run the risk of becoming a bit flippant about testing, and just do it. But actually, it's really important that we consider that different people come from different backgrounds. Different people have been raised in different ways, and their relationship with sex is very different, or their risks for HIV is very different. So we always try to, we are a kind, empathetic team, I would say. So if you feel a bit nervous, just, you know, tell the nurse that you feel a bit nervous, and they'll be able to reassure you. We've got some really kind sexual health nurses on the team. So, and then if you really don't want to come to clinic, just do the home test.
Yeah, do the home test, or find one of your like van stops.
Yeah, follow us on social media, and you can find out where we are. Yeah,
nice.
Well, hopefully that's answered everybody's questions about the sexual health clinic. Yeah, absolutely be assured, not just at the Florey in Reading, but any sexual health clinic, you're going to get the warmest welcome and the best and kindest care. It's what they excel at. But Liz, thank you so much. I have no more questions to ask you. Oh, looks like I'm grilling you. I really wasn't. Thanks for listening to the HIV podcast. If you enjoyed our podcast, please like, rate and subscribe wherever you listen to your podcasts.
You can now also follow us on Instagram and TikTok at the HIV Podcast for behind the scenes insights and video. The HIV Podcast is produced by Thames Valley Positive Support.